Hello everybody, physician Lars Haugom here again, and in this video we're going to be discussing cardiac arrhythmias and how they appear on the ECG. We're going to be discussing a little bit about the origin or creation of arrhythmias, how it occurs, and then we're going to discuss the golden rule, which is how we can divide cardiac arrhythmias into two big groups, the supraventricular ones and the ventricular arrhythmias. And of course, if you like this video, give it a like, a thumbs up, and subscribe for more videos, because I will be making a few more videos on medical topics down the line. And on this first slide, we see three examples here of arrhythmia. Do you recognize them? Of course, you can pause the video and take your time, have a look at them. I'm going to be revealing it. You see AV block grade 3 on top here, a ventricular tachycardia on the left, and on the right we see a ventricular extra-systole, a VES. And these are some of the arrhythmias we're going to be covering. And of course, this video, you can always, when it comes to ECG, you can go as broad as you like, or you can make it a little bit more general. And I hope this video will strike a good balance for medical students, nurses, nursing students, and young physicians. Of course, if you are a cardiologist, you might find the video a little bit simple, but I hope also for more experienced physicians you will find some useful repetition here. Alright, so the first thing we're going to be discussing is how arrhythmias occur. Now, I did a previous video, how to read ECG, and there I had a kind of a lengthy electrophysiological section. I'm going to add an annotation here, and you can click on it if you like to review some basic cardiac electrophysiology. But let's just summarize in general that all the myocardiocytes, they have the potential to depolarize. And all of them are slowly depolarizing by the means of leaking in sodium through slow sodium channels. But they also have this concept or ability that they will be following the ride or the pace of the fastest depolarizer. And the fastest depolarizer is usually located up in the right atrium, in the sinus node. And when this area up here depolarizes, the depolarization wave, which is created, spreads throughout the atria and brings with it all the other myocardiocytes. So we have a kind of a synchronized, nice and smooth depolarization, which is then followed swiftly by contraction. Now, when the depolarization wave reaches the AV node here, it occurs a short pause in the AV node, the PR interval, allowing the ventricles to fill. And then eventually the depolarization wave is transmitted through the bundle of His and through the Purkinje fibers in the ventricles, leading to a ventricular depolarization, contraction, and then eventually the repolarization occurs, a return to negative charge. Alright, and between the ventricles and the atria, there is electrical insulation normally. The tricuspid and mitral valves act as insulators, so the only way of this depolarization wave to reach the ventricles from its starting point up in the right atria is by the AV node. So the AV node is the gatekeeper to the ventricles. Now also I want to just focus on the different areas of myocardiocytes. They have a kind of a different inherent depolarization rate. We see here down in the left here, this illustration I made, we see that atrial focuses, atrial areas of depolarization tend to have the fastest rate, frequency of depolarization, meaning that they are the pacemakers. They drive the rhythm or the frequency of depolarization in the heart, and normally the sinus node is the king of depolarization, the fastest one. And then we come down here to the junction. We see a little bit slower depolarization frequency, and then in the ventricles, the myocardiocytes there are pretty slow. You see, if they depolarize by themselves, you can expect a heart rate about 20 to 40, so they are slow depolarizers. And this fast domino effect spreading of the depolarization wave, as mentioned, is propagated by these gap junctions here, which allow this fast spreading of a change in charge between the myocardial Alright, so what causes arrhythmias? Well, since all these myocardial they can depolarize, if, say, an area, say down here in the ventricles, become very irritated and is driven to depolarizing, it can occur, and then you have a competing pacemaker or a competing site of origin of depolarization. And this can happen by means of irritants or conditions like hypoxia, substances like nicotine, caffeine, stress, increased epinephrine, adrenaline in the blood, and also another origin of arrhythmias can be conduction problems. Because you see these yellow structures here. Please remember they are not nerve fibers, which usually yellow denotes or describes or illustrates on these anatomical drawings. They are rather where these gap junctions or Purkinje fibers, as we call them, where they are mostly concentrated. So it's kind of like a highway for this depolarization signal or wave. It's where it spreads the fastest. So this is just the highway of the change, and you see it here. You see here the sinus node where it's marked, and down here you see Purkinje fibers in the atria, the right atria here. The left one is not shown on this particular illustration up here on the right. Then we have the AV node down in the bundle of His, right here in the interventricular septum, and then Purkinje fibers in the ventricles. And in the ventricles we of course have the left bundle branch and right bundle branch. And blocks here, depending on where they are, leads to different sorts of arrhythmias, which we will be discussing in detail. Alright, so we've arrived at the golden rule. Now, as mentioned, arrhythmias can be grouped in two broad groups, kind of encompassing all the different arrhythmias, with a few exceptions, but we'll get to them shortly. And they are quite easily distinguished on the ECG by just looking at the QRS complex, because you see here on this drawing I've illustrated what these areas in the heart correspond to on the ECG strip. You see the ventricles, their electrical activity, their depolarization, is shown by the QRS on the ECG. So if we have a problem with ventricular conduction, the QRS complex will be affected. So broad QRS complexes show us that we have a ventricular arrhythmia. On the other hand, if we have narrow or completely normal QRS complexes, the arrhythmia problem is originating supraventricularly, above the ventricles. The ventricles are not directly causing the arrhythmia. And the reason we want to make this distinction between the types of arrhythmias is that the ventricles are the ones who are the chambers of the heart that are pumping blood into, respectively, on the right side the lungs and on the left side to the systemic circulation, and therefore they directly influence the hemodynamic condition, the circulation of the patients. While the atria, the supraventricular chambers above the ventricles, supraventricular, they do not directly influence either the pulmonary circulation or the systemic circulation. So ventricular arrhythmias have a more direct effect on the circulation and are therefore by default more dangerous for the patient, while the supraventricular ones, at least acutely, are not as dangerous. But they of course you see things like atrial fibrillation. The patient needs to go on anticoagulants because of a risk of a thrombi formation in the atria. So of course they are not without consequence, the supraventricular arrhythmias, but we'll get to it. So normal duration of a QRS complex is around 100 milliseconds, between 80 to 120 milliseconds, and on a 50 millimeter per second strip this would equal one big block, and on a 25 millimeter per second one big block equals 200 milliseconds. So there a normal QRS should be have a big block. And we discussed this in detail in this other video I made, how to read ECG. So I'll put on an annotation here if you want to review what we see on the ECG strip, what these boxes mean. You can just click on that annotation, I'll put it here, and you can review it if you like. Alright, so this is a kind of a broad overview of all the different arrhythmias we're going to be discussing in this video. You see, you can quite systematically divide them into supraventricular ones and ventricular ones. And I've listed a few sources here where I've taken all this information from. ECGpedia, great site. LVH.no, it's sort of like an official guideline book for doctors on duty used here in Norway. If you speak Norwegian or are comfortable with Google translating everything, you can check it out. And Life in the Fast Lane, a great medical blog about ECG and different medical subjects. I would recommend checking it out if you have the time. Now, so what we mean by supraventricular arrhythmias are all arrhythmias occurring above the bundle of His. And the bundle of His is part of the Purkinje fibers, which is just below the AV node. So AV node and above, it is a supraventricular rhythm or arrhythmia. And the bundle of His and down, so below the AV node, we are talking about ventricular arrhythmias. And in this overview, I've tried to encompass most of the arrhythmias. Of course, there are some things that might not be covered, but if you're comfortable with recognizing all the arrhythmias we're going to be discussing today, you'll have a very solid foundation understanding of cardiac arrhythmias and how to see them on the ECG strip. Alright, so let's start out with the supraventricular ones. You see here, marked by the yellow square. Okay, so when we talk about supraventricular arrhythmias, these will in general affect the PR interval. You see here, it's reflected here in this triangle. And the QRSs will be normal, meaning narrow looking. They will not be directly influenced, at least their form or shape. They might appear more often because of maybe electrical chaos in the atria, and this chaos kind of transmitting down to the ventricles, but the depolarization itself in the ventricles will be unaffected. Now, we will also discuss a little bit about reentry and accessory pathways. This is an interesting group of arrhythmias that are due to either, when it's called reentry, it's kind of a fixed signal, a looping depolarization wave. We're going to be discussing that. And accessory pathways, of course, Wolf-Parkinson-White is this famous example of it, when you have Purkinje fibers in addition to this normal you see here on marked here with blue on this illustration. You have some extra Purkinje fibers that cross this insulating function of the tricuspid and the mitral valve. Alright, so let's start with supraventricular arrhythmias that leads to tachycardia, tachyarrhythmias, meaning a heart rate at 100 or more per minute. So, sinus tachycardia. This is simply when the sinus node is still pacing the heart, but the frequency is more than 100. And this can be completely normal depending on situation, say if a patient is stressed or if you are exercising. Sinus tachycardia is completely normal, nothing abnormal there. But it is interesting to try and distinguish it from what we call supraventricular tachycardia, which is just like a sinus tachycardia. It is a tachycardia that originates in the atria, but it's not the sinus node that is the pacemaker. It's some other focus in the atria outside of the sinus node, so an ectopic focus. And we can do this in a few different ways. The general rule is that if you see P waves in front of every QRS, like here on the left here, you see P waves clearly marked in front of the narrow, normal-looking QRS complexes. This is sinus tachycardia. Now, on a supraventricular tachycardia, we see that P waves are not really clearly visible here. There might be some here, some kind of disturbance along the isoelectric line here, but it is not clearly that a sinus node, the P wave, is pacing the ventricles. So how to distinguish it? Well, you attach the ECG machine to the patient, and while the patient is being monitored on the ECG scope or screen, you can apply a few maneuvers which will increase the parasympathetic input on the heart. And this in general will be by increasing the vagus nerve output. And this can either be done by the Valsalva maneuver, illustrated by this woman here, when you close your nose and try to blow out and increase abdominal pressure. You can also, like, say, if you bear down, like when you're on a toilet, you bear down and you increase pressure in the abdominal cavity. This will increase vagal input on the heart. You can also try what we call a carotid sinus massage, which is gently massaging the carotid sinus here, which is a baroreceptor, a pressure receptor here at the branching of the internal and external carotids, carotid arteries. And what this does is that it slows the heart rate, so it will space out the interval here between the R waves, and this will allow you to identify eventual P waves, of course, if there are any. So if you do these maneuvers and there are no P waves, but still rather rapid, repeating, regularly spaced R waves, you have a supraventricular tachycardia. Now, a supraventricular extra-systole, the second one here, this is illustrated here down in the left, and this is just an extra supraventricular depolarization that occurs before its time, before it should, if you follow a regular pattern here. And of course, if this just happens once in a while, it is of no concern to the patient. There's nothing really dangerous going on usually. Now, another arrhythmia, supraventricular tachyarrhythmia, is paroxystic, meaning suddenly appearing, supraventricular tachycardia. And you see here we have a normal sinus rhythm on the left, and then a sudden conversion to a supraventricular tachycardia. And these are usually self-terminating, and if they are sustained, then of course different antiarrhythmic treatment is relevant to apply. Now, about the reentry tachycardia, the AV node reentral tachycardia, and Wolf-Parkinson-White. These are interesting conditions. AV node reentral tachycardia is usually self-limiting, but it can be bothersome for the patient if occurring often. It leads to an increased heart rate, and palpitations, can be dizziness, and it's not comfortable for the patient feeling that their heart is racing. And what is happening there is that you see, normally when we have a sinus rhythm, we have two Purkinje fibers or pathways through the AV node. A slow pathway and a fast pathway. And usually the fast pathway is overriding, so the signal reaches the AV node, has its necessary pause, the PR interval, allowing the ventricles to fill, and then the AV node discharges or transmits the depolarization wave further down to the His bundle and through the ventricles. And we have a normal looking QRS complex and normal heart rate. But in an AV node reentry tachycardia here, you see that there is sort of like a looping signal. The slow pathway is not completely overwritten, and you have a sustained depolarization going on in the AV node. So, more or less independent of what the atria are doing, the AV node will start acting as a rapid pacemaker, and then overriding whatever signal comes from above and just quickly pacing the ventricles, leading to a faster heart rate. Now, Wolf-Parkinson-White, this is when you have an accessory pathway here outside of this normal pathway by through the AV node into the His bundle and Purkinje fibers into the ventricles. You have an extra Purkinje fiber here, which is a congenital defect. Patients are born with this, and what it does is that instead of having this normal narrow QRS complex, which indicates that conduction through the ventricles are by this orderly fashion through the His bundle and down through the bundle branches. You have an extra means of reaching the ventricles and depolarizing them. And what you get then is a broader QRS complex. And this is one of the exceptions to this narrow QRS complex rule, because normally when we have supraventricular arrhythmias, the QRS complex should be narrow and completely unaffected by what is going on in the atria. But here, unfortunately, the QRS complex will be a bit broader, and you will get this classical delta wave, a more kind of like broad upwards slope here on the R wave. You can also get a secondary ST change, which, of course, when we're talking about ischemia, will make it a little bit more difficult to see. Alright, so another tachyarrhythmia are the atrial flutter and atrial fibrillation. In clinical practice, they are both treated the same. They both lead to rapid pulse, which is irregular, and an increased risk of thrombi formation in the atria, because the atria are just standing and kind of vibrating. They are not pumping effectively, so blood stands still in the atria and are allowed to potentially clot, forming a thrombi. And if the thrombi reaches the ventricles, like say on the left side, gets into the left ventricle and enters the systemic circulation, you will have a bad situation if it enters the carotid artery and then goes up to the brain and lodges in a small cerebral vessel. You will have a stroke. So that is why these patients are given anticoagulants, because it is sometimes a bit difficult to get this atrial electrical chaos under control. So many patients with atrial fibrillation, mostly seniors, they will just be living with the supraventricular electrical chaos going on, the atrial fibrillation going on, and then what we do is that we try to reduce a little bit the ventricular response so that the heart rate goes down by the means of, say, beta blockers. So what occurs is that there are, instead of the sinus node depolarizing and kind of being the normal regular pacemaker, we have hundreds, maybe even thousands of different competing pacemakers in the atria, and the AV node here is bombarded with electrical impulses, but luckily it acts as a gatekeeper, so it prevents a complete distribution of this chaos into the ventricles. But since there are so many electrical inputs, this more rapid depolarization is to some extent propagated down into the ventricles, and we tend to have a tachycardia around 100 to 150 heartbeats per minute. And you see, in the general population it's not so common, but as people get older it gets a pretty common thing. And a quick tip, if you, when you examine a patient, if you are a nurse in an elderly home or a family physician, general practitioner, what you can do is just check the pulse of the patient once in a while, and if it is a fast, irregular pulse, then it is a good chance that the patient has atrial fibrillation or flutter. And this is of course confirmed by ECG. Now on the ECG, atrial flutter has this classical sawtooth pattern along the isoelectric baseline here, while on atrial fibrillation there is more or less flat isoelectric baseline, might be small fibrillation waves, a little bit of chaos along it, but there should be no classically identifiable P waves. The QRS complexes are of course narrow and normal looking. Now we're talking about tachyarrhythmias, so let's talk a little bit about bradyarrhythmias, the supraventricular arrhythmias that leads to a heart rate that is slower than 50 beats per minute. Now we can start with sinus bradycardia. This is in general a normal condition for most patients. It is when, say, you have either a very relaxed patient or maybe someone athletic that have been exercising, they are in great shape, so they have a lower resting pulse. Now you see here sinus bradycardia, it is P waves, pacing the ventricles as normal. There's no artifacts, except for the heart rate being slower. You see here is a 25 millimeter strip, so we jump a few boxes here: 300, 150, 175, 60, 50. So some definitions, some sources define bradycardia as below 60 beats per minute, some below 50, but 50 beats per minute, this is a fairly slow heart rate. Now, sinuatrial block or arrest is also a form of bradyarrhythmia, and what is happening there is either that the sinus node is taking a break for a moment, like here, sinus arrest, or the signal gets blocked within the sinus node. But usually these occurrences are self-limiting, and to distinguish between them is difficult on a normal ECG. Normally you have to do some electrophysiological studies, and this is sort of in the realm of a specialist, like a cardiologist, and a little bit outside of what we're going to be discussing here. But if you see such a break, and otherwise a normal sinus rhythm in between, as long as this is just once in a while, it is not of any major concern. Alright, so let's talk about supraventricular errors of conduction. These are not strictly determined as either tachyarrhythmia or bradyarrhythmia, but AV nodes are the AV blocks are, a well-known arrhythmia, and distinguishing between them is easy if you have a few rules on how to do it. So we have in general 3 types of AV block, and AV block grade 1, this is just when you have a prolonged PR interval, meaning that the signal, when it has arrived in the AV node, takes more time than usual to enter the bundle of His and start the ventricular depolarization, so the PR interval reflecting the pause in the AV node is just prolonged. But every P paces the QRS complexes following them, so it is can also be determined as a sinus rhythm. It's just an increased PR interval. Many people have it, and there are usually not much of a concern for the patient. Now, AV block grade 2 is when you also have a prolonged PR interval, but here not all P waves leads to a QRS. So it is the QRS complex is not always preceded by a P wave. There are 2 types, just to make our life easy. It's Mobitz type 1 or Wenckebach, and Mobitz type 2 AV block grade 2. Now, don't be alarmed by the different Mobitzes, because they are also kind of straightforward to distinguish if you have this nice memory tool. When we're talking about Mobitz or Wenckebach, Dr. Wenckebach, he was the guy who first described this type of AV block. And you see, when you have a Mobitz type 1 or Wenckebach, the PR interval gets increasingly longer, more and more prolonged, until a P wave does not lead to a QRS complex. So what we can say, just a nice mnemonic tool, is that eventually the PR interval in Mobitz type 1 or Wenckebach, AV block grade 2, the PR interval will eventually be so long that you can fit a nice little picture of Dr. Wenckebach in it. Alright, so that's a means of remembering what Mobitz type 1 or Wenckebach is. Now, Mobitz type 2 is when the PR interval is also prolonged, and sometimes it doesn't lead to a QRS complex. But you see, the PR interval does not increase in size. It stays the same all the time until suddenly a drop occurs. And we can also describe Mobitz type 2 depending on how many P waves are needed for each QRS complex. Like here you have a 2-to-1 block, meaning 2 P waves per QRS complex. You can have a 3-to-1, 4-to-1, and so forth. And the clinical importance or difference between all of these is that from a Mobitz type 2 AV block grade 2 and up to AV block grade 3, a pacemaker is usually indicated, cardiac pacemaker, and Mobitz type 1 or Wenckebach and AV block grade 1 does not immediately require an external cardiac pacemaker. Now, AV block grade 3 is a complete AV block. There is no association between what is going on in the ventricles and what is going on in the atria. So the ventricles will eventually start to pace themselves. The patient will have what we call, to some degree, a ventricular escape rhythm, or it could be a junctional escape rhythm. But anyway, it will be usually a slower heart rate, and the patient is in need of a cardiac pacemaker, because this slow heart rate will probably not be up to the task of supplying the patient with sufficient systemic blood flow or circulation. It will be a too slow heart rate. So a nice memory tool just to distinguish all three from each other is that first, second and third degree, all, some, none. Meaning that in a first degree AV block, all P waves leads to QRS complexes. Second degree AV block, some P waves leads to QRS complexes. And in AV block grade 3, none of the P waves leads to QRS complexes. Alright, so good job. Now we've covered all the supraventricular arrhythmias nice and effectively, and now we're going to be discussing the ventricular arrhythmias, which we remember are concerning the QRS complex and has a more direct effect on the blood circulation, the systemic and pulmonary circulation. And just the same, we can divide them into ventricular arrhythmias that cause tachycardia, the ones that cause or result in bradycardia, and the ones that can be described as being errors of conduction affecting the Purkinje fibers in the ventricles. And then of course the most famous example of this is the bundle branch blocks, left and right. Alright, so just a short reminder here, arrhythmias, these ventricular arrhythmias will affect the QRS interval. The PR interval is unaffected, and you see here QRS complex reflecting directly the depolarization or electroactivity in the ventricles. Now let's start out with the ventricular tachyarrhythmias. Then we have, let's start out with with the ventricular extra-systoles. These are when a focus in the ventricle decides that it's time to depolarize, probably ahead of time or before it should. And what we get is this huge looking QRS complex. And the reason it is so big and so, not to say very broad, is because when one focus in the ventricle depolarizes, it does so outside of this kind of highway of Purkinje fibers, so the depolarization is not smooth and elegant and quick like it normally is when it happens along the bundle of His and propagating through these Purkinje fiber highways of depolarization. So we compare it. Here you see a normal ventricular depolarization happening because of a signal from a higher rhythm center, like say from the AV node, the bundle of His and so forth down. But it happens outside of this and we get a very broad, large QRS complex. Now in and of itself, ventricular extra-systoles are completely benign, but if they happen rather often, and there are different literary sources on this. The Norwegian guideline for emergency medicine on this, lvh.no, states that more than 6 per minute should be considered for further examination by maybe a cardiologist, because this could indicate that we have some kind of ectopic foci or focus in the ventricles, which is being irritated by maybe, say, ischemia, hypoxia. Okay, and another thing to just before we leave the ventricular extra-systoles be, remember an important concept is what we call R on T. This is when we have an R wave of a ventricular extra-systole which occurs on top of a T wave here, and this is described in literature as being more associated with potentially ischemia. Now, when we talk about ventricular tachycardia, this is when a focus in one of the ventricles become kind of sustained. It just keeps on running and is a constant pacemaker in the ventricles. And this leads to very broad QRS complexes, which happen at a very rapid rate. Like say here we have let's say 300, 150, between maybe 170, 200 here beats per minute, which is a rapid heart rate. Now this R on T, which we just mentioned, ventricular extra-systole, increases the risk of such a ventricular tachycardia occurring. Now, ventricular tachycardias, these patients can be in different stages of hemodynamic or circulatory instability. Some patients I've seen with ventricular tachycardia when I was working in the emergency room in Ålesund Hospital, some of them would be completely conscious, of course feeling their heart racing and feeling the palpitations, uncomfortable because of it, but were conscious and responding to questions and being available. Well, other patients can be kind of dizzy in and out of consciousness, and it is not an ideal condition, because the big scare is that it will progress into ventricular fibrillation, which we'll get to in a second. Now, you can describe ventricular tachycardias as either monomorphic, meaning that they have a more stable shape like here, or polymorphic, which is this famously named torsade de pointes, which is a ventricular tachycardia where you see it kind of like snakes around this isoelectric baseline. It kind of twists around it. And they are usually associated with a worse hemodynamic condition than a monomorphic ventricular tachycardia. Now, when we talk about ventricular fibrillation, this is effectively cardiac arrest. And of course, immediate CPR and defibrillation is life-saving. Cardiac arrest is cardiac arrest. Now, you see on the ECG, it's of course, if you look at the patient's cardiac arrest, they are not conscious, they are not present at all. But you see on the ECG, you see this kind of chaos along the isoelectric baseline. It's very difficult to do. You cannot see any particular waves. It's just chaos. Now, this is a better situation than if we have what we call a systole, which is just a flat line. And when you have a flat line, depolarization or defibrillation is in and of itself, and it's not indicated, because what you do when you defibrillate, you give an electrical shock which knocks out all the myocardiocytes, giving off this chaos, and you allow the sinus node to overtake and restart this nice normal pacing of the heart. Now, if you have a flat line, an asystole, there is no electrical chaos to knock out, and patients with this kind of cardiac arrest have a poor prognosis, a poor outlook. Okay. Okay, so when we talk about bradyarrhythmias in the ventricles, now we mentioned before ventricular escape a little bit. It looks like a ventricular extra-systole. It looks like a giant QRS complex, but you see it occurs after a break, a sort of like pause, a lacking of input from a higher rhythm center. So what happens here is that say if you have say you have an AV block grade 3, not present on this ECG strip here, but so let's say you have it and there's no signal coming down from the upper rhythm centers. A group of myocardiocytes eventually in the ventricles will, as all cardiomyocytes do, they will depolarize by themselves. But they do it much slower and more uncoordinated than what happens when these signals follows this normal highway of depolarization. And you get big, broad QRS complexes. And this is life-saving in that it keeps some form of pumping action going in the heart, but normally the frequency is too low to sustain a good circulation. Now, let's talk about errors of conduction in the ventricles, and then, of course, the bundle branch blocks are the most known example of this, and we divide it into right-sided bundle branch block and left-sided bundle branch blocks. And difference here, clinically speaking, is that right bundle branch blocks can be normal variation. It can be found, especially in men. It's not uncommon to find it, young men. On the other hand, left bundle branch blocks, if they are newly arisen, and especially if they have clinical signs of acute coronary syndrome, like pressure sensation over the chest, a tight feeling retrosternally, radiation up towards the jaw, left shoulder, arm, and so forth. It should be treated as a non-ST elevation myocardial infarction until proven otherwise. And this can be proven by either ultrasound examination of the heart or biochemical markers like creatinine kinase and troponin. Now, to see the difference between these two types of bundle branch blocks on ECG, because they have a common morphology in that usually their QRS complexes will be broad, because the conduction through the ventricles, through the Purkinje fibers here, through the left and right bundle branch blocks, is impaired. So the depolarization does not occur as rapid and smooth as normally, so we get more broadened QRS complexes. Now we look at to distinguish these two, we look at the shape or form or morphology, if you like, of the QRS complexes. What we will expect when we have right bundle branch blocks is sort of like M shapes, biphasic QRS complexes in the right precordial leads, V1, V2, and in V6 we will see more or less kind of like a W biphasic QRS complexes. While in a left bundle branch block, what we see on the right-sided precordial leads is this W-like shape here. It's a small R and a big S wave. And on the left precordial leads, we will see on the V5, V6, we will see sort of like the M's, biphasic QRS complexes. Now, a good mnemonic tool for this is William-Morrow. William being W and M, W on the right side and M on the left for left bundle branch block, and Morrow for right bundle branch block, M on the right side and W on the left. Now, anterior anterior fascicular block, posterior fascicular block, or hemi blocks are subdivisions of left bundle branch blocks, because the left bundle branch block divides into two big groups, or two big branches, if you like, and either one of these two can be separately blocked, leading to also this kind of like change in on the ECG. Now, unfortunately, they will have a normal QRS duration and shape, so it's not as apparent as, say, the normal left bundle branch block or the right bundle branch block. But the reason it's very interesting to recognize this is that they are a subdivision of left bundle branch block, and therefore, if they are newly arisen, they just the same should be treated as an end-STEMI until otherwise proven. So they are important to recognize. Now, just so you know it, anterior hemiblocks are much more common than posterior hemi blocks. And the way to try and determine it is if you have a left axis deviation without any obvious other causes of this left axis deviation, like say left ventricular hypertrophy or increased abdominal mass, like a overweight patient where the diaphragm is pushed upwards and likewise the heart is also pushed up to the left. If you have no such cause for left axis deviation, you should start to consider the possibility of anterior hemi block. Also, they tend to have a small Q wave in AVL, but this might be a bit difficult to remember in your clinical practice, among all the other things you have to remember. So, if you have a left axis deviation without any other obvious cause, consider anterior hemiblock. Now, posterior hemiblock, on the other hand, has a tendency to give a right axis deviation, and the same applies if you have no other obvious cause of this right axis deviation, like say right ventricular hypertrophy by means of chronic obstructive pulmonary disease, COPD. You should maybe consider a posterior hemiblock, but this is a fairly rare occurrence. Alright, well done. Now we've reviewed different cardiac arrhythmias and how to see them on the ECG strip. And remember the golden rule: if it is a narrow or normal looking QRS complex, then you are most likely dealing with a supraventricular rhythm. If it is a broad QRS, you are probably dealing with a ventricular rhythm or arrhythmia. Now, if you like this video, hit the like or thumbs up button. If you like more medical or videos on these medical topics, hit the subscribe button, and take care. Physician Lars Haugom signing out.